thank you for meeting us today, Dr. Keenan. And hopefully the aim of this interview is to inform our readers about cardiology and everything involved with cardiology. So my first question is, having attended Oxford for your Masters, since you're all aspiring medical students, what was your experience like at Oxford, and what's different about Oxford compared to other medical schools possibly?
I think the first thing is that it's 6 years course, and so everyone has to do an integrated BSc, although they call it a BA in physiological sciences. So you do the first 2 years of the medical course, you then come out of that and do a year of physiology, and then you go back into the clinical course. So that's a much more traditional model where the preclinical and the clinical are separated. And in fact, a lot of people, maybe in my time, about half the year, changed medical school completely. We had people joining us from Cambridge, people going to London, and so on. So, I think the traditional course is very good. I think people appreciate that. I think having solid grounding in the basic science before going onto the wards is very helpful. Being part of a university rather than just a medical school with all the sport, that's very important. Also, of course, you're in Oxford and Cambridge, you're in a college, and so there's maybe 300 or 400 students who are all studying different things. I did a lot of rowing and things like that. I think the downside for some people is that there's not very much exposure to patients in the first couple of years, and for some people really want that, and other medical schools follow much more. For example, Southampton has a thing where people are on the wards really from day one. So, it's a different model. But no, I think Oxford's a fabulous medical school. I've got a lot out of it. There's also, you have to do dissection. And a lot of places that's been abandoned now. But so learning anatomy through dissection of cadavers and things, which, some people feel a bit queasy about, but I think it's very helpful.
It's nice to have your hands-on experience.
Yeah, I think, especially when you do surgery and so on, that kind of thing.
All right, thank you.
Well, so you now obviously moved on to specialise in cardiology. So what are some of your main clinical interests?
My main clinical interests are, so I'm a cardiologist. I'm interested in cardiac imaging, which is to do with different ways of looking at someone's heart and how it works. The mainstay of that is something called echocardiography, which is ultrasound applied to the heart, just like a pregnant woman having a scan of their tummy, but on the heart. That's called echo. In this department here, what we're interested in is cardiac MRI, which is using an MRI scanner to look at the heart, and then cardiac CT, which is looking at the arteries around the heart with a CT scan. Echo's been around for a long time. Those last two have only really taken off in the last 10 years or so, because the technology that was required to get the scanners to go fast enough to look at a moving structure like the heart wasn't available, but it is available now, and so they're becoming increasingly important in the assessment of patients. So that's what I do in terms of imaging, and then in terms of patients, looking after inpatients in our hospital in Watford, doing outpatients, for patients with a whole range of problems who their GPs want to see a cardiologist, palpitations, chest pain, breathlessness. And then I'm personally interested in heart failure, which is a syndrome where patients' hearts don't beat hard enough and they start to get breathless and fluids filling up on their ankles and so on. And something called valvular heart disease, which is where the four valves of the heart either get narrow or start leaking. So I think that those are my main clinical interests. In terms of research, my research interest has been using MRI to look at vessel walls. We've done a lot of work looking at the carotid arteries in the neck to look at what factors affect the thickening of the arteries. And also, I spent some time in France where I did research in valvular heart disease as well. So that's a broad overview of my interests.
So you'd love to know a little more about your research into cardiac MRI and what you're doing at the moment.
So, in this department, what's going on at the moment is that my colleagues research across the whole range of medicine at the moment. There's a big interest into what's called genotype-phenotype studies, which are looking at the patient and seeing how they are in various ways, blood tests, scans, whatever, and doing a genetic profile and seeing how these tie up. So in this department we've just finished, mainly my colleagues, not me, about 1,000 patients where they've all had MRI scans, they've all had their genes analysed, and when you start to get quite big numbers like 1,000, you can then start to see trends for things at the genetic level which are a bit more minor. So, you know, there are genetic conditions which it's obvious there's cystic fibrosis or something like that. There's a gene that causes it, but there's a huge range of other things. You know, why is there a range in blood pressure? Why is there a range in how thick your heart muscle is? Why is there a range in lots of these things? And all these things are affected by lots of genes, each of which has just a small effect. So you need bigger studies to look at that. This is a very big project going on at the moment, which is recruiting called the UK Biobank, which is much, much bigger. I think it's hundreds of thousands of patients using the same sort of approach.
Yeah.
So that is one type of thing where you look at very big things. In MRI, you know, my own work has tended to be on much smaller numbers of patients with rarer conditions. So we've got, I personally have an interest in a condition called Takayasu's arteritis, which we have a lot of patients of in this hospital, but it's a very rare condition. And we look at their arteries and see the thickening of their arteries and so on.
Yeah.
And then between research but also clinical in this particular area of the hospital, we're interested in cardiomyopathy, which is disease, broadly speaking, disease of the heart muscle.
Yeah.
Can be inherited, can be acquired, and so we do quite a lot of work looking at MRI and heart muscle disease.
So what has been the process from the beginnings of your research until the stage you're at now?
Starting when?
Well, starting, I
Medical
guess,
school.
before, yeah, well.
I think that people have to decide early on what sort of, you know, as you go through the training, it becomes clearer where you want to end up.
Yeah.
But it can be helpful at the beginning if you have a vague idea of, you know, the likely destination. Yeah.
Yeah.
And it does vary though, because for example, the number of people who in day one of medical school say they want to be a GP is quite low.
Yeah.
But I think over half of all doctors, all medical students do become GPs, and in my year, I think approximately half are GPs. So, you know, if someone embarks on day one saying they want to end up as a sort of professor of neurosurgery or something, that may be where they end up, or it may be that actually as they get more into things, they realise that actually it's not what they want. So if I think about myself, you know, in the holidays of medical school, for example, I spent time in some of the research laboratories in Oxford doing little projects and things, because if you do something like that, you can hopefully try and get a publication out of it. And you know, so you get exposed to the research environment, you see what it's like working in the lab, which you don't tend to do so much as a medical student, and also you can try and get publications out of that, which are very helpful later on. And then, as well as the clinical training, you're meant to, if possible, on the side, have some small research projects going on. It can even just be looking at 50 patients and trying to look at a small thing like how people have done after a heart attack or something like that. But then for most trainee doctors who are embarking on a career where they want to incorporate a lot of research, people will have to do a PhD or an MD, which is another postgraduate degree. And that's very valuable because it's a 3-year period dedicated to research. So, I mean, I'm not mainly an academic doctor, I'm mainly a clinical doctor. I just do a little bit of research on the side. But you know, I've had to do that, and I found it very valuable. For doctors who are mainly research and a little bit clinical, it's particularly important.
Yeah.
But it's a valuable period of time, just where you're basically never on call. You don't have all your ward commitments. You don't have all these other things. You get time just to focus on research. Because I think this is an important general point that most doctors, and people who want to be doctors, are primarily focused on helping patients for obvious reasons. If it's a choice between spending time with your spreadsheet or going to help look after patients in clinic, most doctors would probably prefer the second one. So they need to be protected from that to spend time focusing on the research. That's why it's valuable.
So what was it that initially fascinated you about the heart?
My father's a cardiac surgeon, so we've become a big family of doctors, but I suppose that must have been a factor. And I think if you decide that you want to do hospital medicine, and you don't want to do something specific like, I don't know, pediatrics or psychiatry or pathology or something like that. You're left with the main area of hospital medicine, which is medicine or surgery.
Yeah.
And then you have to make a decision really based on how good you think you are with your hands, how much time you want to spend. I mean, surgeons spend time in the operating theatre, that's the bottom line. They do clinics and things like that, but if you're an orthopaedic surgeon, you do hip replacements. If you're a vascular surgeon, you do vascular operations or whatever. So that's the next basic decision. Do you want to do surgery or do you want to do medicine? I didn't particularly want to do surgery, so I decided to want to do medicine. And then medicine is divided up into all the different specialities, lungs, heart, kidneys, liver disease, and I always just liked cardiology. I mean, I think the heart's a moving structure, and I think, unlike the brain or your kidneys or whatever, it's dynamic. There's also something about the patients with heart disease are often people you can really help, because if you mention, if you're a respiratory physician, many of your patients will have smoking-related lung damage, and although you can give them inhalers and things like that, there's not a huge amount you can do that's going to really transform someone's life and that they're going to say, I feel like a new person. But for patients who've got angina, they can have stents and then their chest pain goes away. For patients who've got heart failure, they can be put on medication and return to normal life if all goes well. For patients who've got problems with the valves of their heart, they can be replaced and the pain. So it's a very active and engaged area of medicine where you can get a very, very good result for patients. So I think that's broadly what I'm interested in.
Did you find as a medical student and as a junior doctor that you got a chance to experience lots of different specialties?
That is very much built into the course now. They have all these. The course used to be focused on the main areas, medicine, surgery, obstetrics and gynecology, psychiatry, but they've incorporated lots of what they used to call SSMs. I think there was something study modules, special study modules, and there were weeks and weeks set aside for those. And you could do basically almost anything you wanted. I did 2 weeks in Broadmoor with the forensic psychiatry department. I did something on some kidney transplant, and so and I think as people sit there, as medical students sit there and look at the catalogue of options available, it sort of slowly becomes obvious to them what they're actually interested in and what they're not. So it becomes clearer. The course is well set up, I think, to help you.
Yeah. So what would your day be like?
My day?
Cardiology.
My average day?
If you have a typical day, yeah.
Well, we have a thing where and this is quite typical in lots of specialties, I think, for maybe 1 week in 8 where you're in charge of all the patients on the ward or looking after all the patients on the ward. So in a week like that, you show up in the morning about 8 o'clock, do a ward round, go and see all the new referrals, make plans for those patients, and then we have a lot of these meetings where we meet with other colleagues, cardiac surgeons, things like that, planning the treatment for patients, time in the afternoon talking to the relatives, and then do another ward round in the evening and see all the new referrals. So that is when people are on the wards.
Yeah.
My other weeks are quite mixed. Sometimes I do outpatients. Fridays I do come here and do cardiac MRI lists. Other days we do lists of echocardiograms where you sit there, meet the patients, look at the scans of their heart, write reports on them. We do a lot of stress testing of patients where this is usually for people with chest pain, where you do a scan of their heart and then you put a needle in, give them medicine, a bit like adrenaline to make their heart beat quicker. That's there's small risks associated with that test, so it has to be supervised by a doctor, and then you do it. So that's very varied. And then there's unfortunately a lot of time spent doing administration, reading through reports that have come back from tests you've asked for patients. Then there's time spent supervising junior doctors. All junior doctors have an education supervisor, and you meet with them to ask how their things going. But then there's quite a lot of time spent going on courses, teaching on courses, whole sort of education side of things. That probably covers most of what I have to do.
Thank you so much.
Pleasure.
Well, I would imagine that being a consultant, it must entail a variety of challenges. such as dealing with stressful situations, for example.
Yes.
And obviously, growing up wanting to do medicine, we've been told many times that it's a very stressful career. So could you perhaps go into detail about what challenges you do face and how you overcome stress?
I mean, that's a very good question. I think that, if you think about stress, okay, I would say there's probably, I'm just off the top of my head thinking about two broad kinds of stress. There's like immediate stress, and there's just sort of more long-standing chronic stress. So immediate stress is a stressful situation, and that would be something like a cardiac arrest. Okay, you're sitting there, or your bleep goes off, and one of the patients on the ward has had a cardiac arrest. You have to run up there and resuscitate them. Okay, I think everyone would agree that's a stressful situation. That's not just something that I have to deal with. That's something that all doctors have to deal with. Every junior doctor has to be trained in resuscitation. Everyone has to be part of what they call the crash team, which is to do with resuscitating patients. But the way that people deal with that sort of stress is basically because everyone is trained with how to deal with it. There's a course that everyone does called ALS to do with that. There's an enormous amount of practice with mannequins and all this sort of thing. So in the actual environment where a patient has actually had a cardiac arrest, everyone knows what to do because everyone's practiced so many times on the mannequin and so on. So actually, it's not that stressful in that situation because everyone knows what to do. The stress actually comes often if things go very badly wrong, the patient dies and so on, and then you're often left talking to the grieving relatives, trying to explain what happened. I think in many ways that takes a bigger toll on doctors than just if they're in that situation a lot. There's a sort of chronic emotional stress. More generally, I think there's a stress that's just to do with taking responsibility for other people. In our system, and particularly in the NHS, the responsibility, broadly speaking, lies with the doctor. Most patients are very trusting, and they expect that the doctor is in charge of things. So, although maybe, let's say we've got 30 patients on the ward, there may be hundreds of patients who I've seen in my clinic and arranged tests for and things like that. And I'm relying on the rest of the team, the hospital, the administration, that those tests are going to happen, that I'm going to get the results, I'm going to meet the patient and so on, and I'm going to go through the results. And if there are problems with the administration and all this sort of thing, and you don't feel confident the reports are going to come back to you, or you're worried about patients, you've seen someone in clinic, you don't feel that they're that good, but you don't think they're bad enough to bring into hospital, then you do sit there worrying about, I wonder if Mrs. Jones is okay, or if she's having a problem, or, a lot of particularly elderly patients are very accepting of things going wrong, and they don't come back, they don't make contact if their breathing's getting worse or their chest pain's getting worse. They often have the attitude, doctor knows what's going on. They don't come and make contact with my secretary or whatever and say things are getting worse, please can I come and see you again. Now, and there's a third thing I would say. In cardiology, this doesn't affect us so much because most patients are broadly happy with what's going on. If people come into hospital with furring up of the arteries and blocked arteries, they don't feel, in my experience, quite surprisingly, they don't feel particularly guilty about it. They just sort of say, oh well doctor, I've eaten all the wrong food, I've smoked a lot, it's bound to happen. I think doctors who deal with cancer, where quite a lot of patients die, a lot of patients are very emotionally traumatized and very upset, and the most extreme example of patient doctors who deal with cancer in children. I think, I've not had experience of that, but I think that can be emotionally very traumatizing and very stressful for the doctors involved, and it needs a special sort of person to be able to cope with that and then move forward. In terms of how people cope with stress, the second part of your question, I think the answer is by having something outside work, a strong family life, sport, other activities. I think people do need to be able to unplug, and I think that in more high pressure specialties, I think cardiology probably is included in that. There is a bit of a sense that people are expected to be able to work all the time, and people trying to move away from that to a situation where people don't feel they have to be able to work all the time, we're governed by something called the European Working Time Directive, which it's meant to limit the number of hours that people can do a week. But if you ask around, you'll find out most people are working, quite a lot in excess of those hours through their own choice. And sometimes I think people do need to be told, that's enough, go ahead.
You spoke briefly of the responsibility that you have for your patients.
Yeah.
And clearly, this is a quality that most aspiring medical students should hope to have. But are there any other qualities which you think are important in a medical student?
Well, being interested in the subject. I mean, the very basics are obviously true. Being good at science, being interested in the subject, all of that's important. But I think sometimes that's overhyped. You obviously need to be able to handle the course and be good at science. But I think there are many people who come into medicine who are very focused on medicine as science, medicine as an academic subject, and so on. And sometimes the human dimension gets missed. It's fundamentally a subject about looking after people, not just about science. And so I think if people are thinking about doing medicine, and when they look deep in their heart, they realise that what they're really interested in is academic interest, status, money, or whatever. They should do something else. They should do finance or something, because I think, and I fundamentally believe this very strongly, that people who do not have a strong humanitarian impetus in what they're doing will eventually come a cropper, because after many years in practice, you sometimes see this with colleagues, they just sort of disengage. You've got to be really committed to wanting to help people. That's why that question that people are asked in medical school interviews, which people sometimes think is a joke question, is actually quite a good question. Which is people say, I want to help people, and some people say, why do you become a nurse? And I think people think, oh gosh, no, that's completely different. Being a nurse and being a doctor are very similar. They're both to do with looking after people. One one's good, has got more academic training than another, but if someone thinks to themselves, I would never in a million years dream of being a nurse, then maybe they should think, is medicine ready for them, because it's still looking after people.